Good morning again to those who are joining us. We will get started in just a few moments here. Hey, good morning, everyone. We'll give it about one more minute before we get started. So I know that there's still folks hopping on this morning. So thank you for joining. Okay, we are a couple minutes past the hour here, so I think we'll just start to sort of get the ball rolling this morning. Thank you again, everyone, for joining us on this Wednesday morning. My name is Suman Mathur, and I'm with the Colorado Health Institute, and we're excited to have you join us for this morning's Hot Issues in Health webinar series. This morning, we'll be discussing the limits of coverage using data from the Colorado Health Access Survey. And specifically, we'll be talking about the concept of underinsurance. We often use the CHAS to talk about insurance coverage as well as uninsurance. And today we'll sort of be talking about what happens when folks are covered, but that coverage might have some limitations here. Again, we appreciate you joining us nice and early, or early for me on this Wednesday at least. And as we get started here this morning, I'd love to hear a little bit about who is joining us in the room or in the virtual room this morning. So please feel free to put your name, your organization, and it is the back to school season. And while I myself am not going back to school, I still have the urge to buy a new notebook. So I would love to hear what your favorite school supply is as well. So name, organization, and favorite school supply. And before we start, and while folks are still thinking about the merits of a protractor over a ruler here, I'll just start with a few logistical items as well. We are recording today's session, and we'll send a follow-up email with a link to the video as well as to the report that we'll be talking about in today's webinar. We'll save time for some Q&A at the end of the webinar, but if you do have questions as we go throughout the presentation today, please feel free to drop those in the chat. We'll monitor the chat throughout the webinar today, and when we get to the Q&A portion at the end, we'll go through and answer questions as best as we can. Also, at the end of our webinar, when we get to Q&A, we'll invite folks to come off mute and share your question with the group as well. Okay, let's take a look here at what people are saying in terms of favorite school supplies. Sticky notes, fresh pens with multiple inks, a lot of pen people here, colored pencils, markers, sticky notes, mechanical pencils. Yeah, Joe Hannell told everyone that protractors were his favorite school supplies, which we all thought was a little bit out of left field, but to each their own. All right, lots of great opinions on school supplies in the chat. How about we go to the next slide? All right, so again, seeing some familiar names in the chat as well as some new ones. So thank you everyone for joining us. Before we get started, I do just want to share a little bit about the Colorado Health Institute, or CHI, if you are newer to hearing about us. We are a nonprofit public health institute that works to improve the systems that influence people's health and well-being. We provide resources for people who are seeking to make those systems more effective and equitable. We do that in a few different ways by answering critical questions, making sense of complex issues, and supporting others to reach actionable solutions. And one of the tools or resources that we use to do this work is the Colorado Health Access Survey, or the CHAS. And while we are perhaps more well known for the CHAS, and that's what we're talking about today, we also support our partners in a variety of other ways through analysis, evaluation, facilitation, and many other services. We often partner with community groups as well as state and local government agencies, foundations, providers, and others. And we welcome the opportunity to discuss how we might support your work in any way. Next slide. Okay, great. And so I know I already briefly introduced myself, but I'll just share a little bit more. Like I said, my name is Suman Mathur, and I'm a director here at the Colorado Health Institute, where I've been for about 4 years. I lead the Colorado Health Access Survey and get to lead our team of researchers, including Lindsey, who really use this data to help inform and think about really interesting policy discussions and ideas, including the one we're talking about today. So with that, Lindsey, I will turn it over to you to introduce yourself.
Hi, everybody. Good morning. Nice to see everybody on the call today. Lindsey Whittington. I am the data and analysis manager at CHI. I've been here for about 7 years now. Super cool to see lots of familiar names in the chat, lots of different data requests that I have filled for lots of you on the call today, but just really excited to dive into this new research that we are presenting on today.
Thanks, Lindsey. So before we get to sort of the good stuff here in the research, I do just want to provide a little bit of background information about the Colorado Health Access Survey, which we call the CHAS. So the CHAS is Colorado's premier source for data on issues like insurance coverage, access, social factors, and more. CHI has conducted and facilitated the CHAS since 2009, which means that we will be sharing, or we have the ability to share, data that trends back to 2009 to really allow us to look at how things have changed over the last couple of decades of pretty big policy movements in the health policy space. We also know that it's important to be responsive to community needs and emerging issues. And so every year we sort of look back at the survey and think about topics that we might want to add or modify to really capture the changing needs of our partners when it comes to having this research. And finally, we do what we can to make our data as free and publicly available as we can in a variety of formats. So on the screen there, you can see just a preview of a few of the data tools that we have available. And we'll talk more about what all we have available in those resources later in our presentation today. Next slide. Okay, so in our webinar today, we'll be sharing data that trends from 2009 as well as all the way to our 2025 survey. And so just a few nuts and bolts about our 2025 survey. It was in the field and conducted from February to July of 2025. So while that is already a year ago, in many cases, having 2025 data, this is still sort of one of the more fresher data sources that really captured what was happening last year. Our survey represents the voices and the feedback of over 10,000 Coloradans who have the opportunity to respond either online or by phone, as well as in English or Spanish. And then we also do some work on the back end to statistically weight the data to make sure that the data that we're sharing with you is representative of all Coloradans or of specific communities within Colorado. And finally, I'd be remiss not to thank our sponsors of the 2025 CHAS. Our lead sponsors are the Colorado Health Foundation, as well as the Colorado Trust. And we have a number of other sponsors who have committed to the survey over the past few years listed here. These sponsors not only help us actually field the CHAS and collect the data, but allow us to continue to do plenty of data analysis, including the work that we're sharing with you today. Okay, that's all I have about sort of the nuts and bolts of the CHAS, and I will turn it back over to Lindsey to get to this research.
Thanks, Suman. All right, so let's dive into the content for the presentation today. So for this specific analysis that we are going to be chatting about today, we wanted to go beyond simply looking at insured and uninsured. Much like Suman mentioned at the beginning of the presentation, which these two things are two very important topics that CHI spends a lot of time exploring. Instead, we wanted to understand who is underinsured and what it means for health and policy in Colorado. So I'm going to walk us through kind of our three key findings from this analysis. The first of which, we found that about 1 in 8 Coloradans is considered underinsured, meaning that they can't afford to access the kind of care that they need despite actually having health insurance coverage. The second of which is underinsured Coloradans have health outcomes similar as those who have no insurance at all. And the third of which, we found that underinsured Coloradans are more likely to live with a disability, be working age adults, and identify as Hispanic or Latino. So now let's dive into these three key findings more specifically. So let's start with the big picture. We're going to look at insurance coverage trends and what exactly we mean when we actually say underinsured. So this first figure shows us the uninsured rate over time in this gray bar, as we have really captured this data point on the CHAS since the beginning of the CHAS in 2009. We can see across this time period a significant decrease in the percentage of Coloradans who are uninsured, most importantly due to the Affordable Care Act passage and implementation, where we really see a big decrease from 14.3% in 2013 to 6.7% uninsured rate in 2015. For the last decade, there has been a more consistent trend in uninsurance, with CHAS measuring the uninsured rate at 5.9% in 2025. So now let's look at healthcare affordability. This green line is the percentage of people in Colorado who were unable to get general doctor care, specialty care, or prescription medicines in the last year due to cost. This metric has stayed consistent since 2009, with the percentage of people reporting healthcare affordability issues around about a fifth of Coloradans, with 21.8% of people reporting healthcare affordability issues in 2025. So while we have a significant change in uninsured rates during this time period, there really hasn't been a change in the percentage of people reporting that they couldn't actually access needed care due to cost concerns. Now, let's look a little bit more specifically at that healthcare affordability metric by insurance status. So this figure looks at the percentage of people who didn't get needed doctor care, specialty care, and prescription medicines due to cost. And this first gray bar that we're looking at here together shows the healthcare affordability metric since 2013 for the uninsured population. While this purple bar shows this same exact metric for the consistently insured population, meaning that they had consistent insurance coverage for the last 12 months. We can definitely see that having insurance coverage really makes a big difference in being able to afford healthcare. Since 2019, over half of uninsured Coloradans were unable to get needed care due to cost concerns, with 53.6% of Coloradans reporting healthcare affordability issues in 2025. Now, comparatively, again, in this purple bar, the percentage of uninsured people reporting, or excuse me, insured people reporting the same affordability metric is much lower, fluctuating over time between about 15 to 18%, where we see that about 17.7% of insured Coloradans reporting healthcare affordability issues in 2025. And this makes sense, as health insurance coverage helps cover the cost of care in many scenarios. However, it's interesting that this number is not zero. We still see over 1 in 6 insured Coloradans not getting the kinds of care that they need because of these cost concerns. These insured Coloradans is the population of people that we're going to further explore today, those who are considered underinsured. So underinsurance is when people have health care coverage, but they still run into issues affording the kinds of care that they need. And this can be measured in many different ways based on the data source. So based on data that we are using from the Colorado Health Access Survey, say CHI is going to define underinsurance as those who have insurance continuously for the last year and who have missed needed care because of cost, which includes not getting, again, general doctor care, specialty care, or prescription medicines. So this is how we are measuring those who are underinsured on the CHAS for our presentation today. So with this definition in mind, we can track this population over time to see if underinsurance has shifted at all in the last decade. So first, let's look at how we have historically visualized insurance coverage on the CHAS. This figure looks again at Coloradans by insurance status, but instead of line bars, we're going to look at it in 100% for the whole Colorado population. So in purple, we have those who are insured, and in the gray, we have those who are uninsured. So this shows the same data again as our previous slide, with a shift in uninsurance between 2013 and 2020 or 2015. Again, that drop from 14.3% to 6.7%. And again, we see that the 2025 uninsured rate is 5.9% on the very far right. So now let's look at the percentage of underinsured Coloradans across this exact same time period. So we're pulling out those underinsured people from the overall insured population, and they are displayed here in the yellow. So we've broken out this underinsured population, and what we really see now is those that are considered underinsured in the yellow and those who are considered adequately insured, those who have not faced these affordability problems related to accessing medical care in the last year. So for the purposes of this presentation, those who are insured but don't face these affordability concerns, we are going to be calling them adequately insured for the rest of the presentation. So interestingly, while we do see those shifts in uninsurance during this time period, 2013 to 2025, we have not seen any changes in the percentage of people who are underinsured. Since 2013, this number has measured at about 11 to maybe 14%, with no real shifts in this percentage between 2013 and 2025, as we saw with uninsurance. In 2025 alone, we found that about 13.6% of Coloradans were underinsured. This matters, as this represents over 800,000 people in Colorado in 2025. These people face specific affordability challenges, and as we will see in the next section, specific health challenges. So now that we have that definition of underinsurance in mind, and we know a little bit more about the number of people who are considered underinsured, let's explore what this means for Coloradans who fall within this category. Unfortunately, being underinsured, much like being uninsured, has consequences on health outcomes. On the CHAS, we have two self-reported health outcomes related to mental health and general health status. First, let's look at poor mental health. So this figure looks at the poor mental health rates by insured status. So this is the percentage of people reporting 8 or more poor mental health days in the last month. And in the purple, which again is those adequately insured, we see a poor mental health rate at about 17.2%. For underinsured, we see a poor mental health rate reported at 34.4% in the yellow. And in the gray, we see a poor mental health rate for uninsured folks at 32.7%. And this is really striking because we see that those who are adequately insured are twice as less likely to report poor mental health in the last month compared to those who are both uninsured and underinsured. And so now let's look at general health status. So this figure looks at fair or poor general health by insurance status. And again, we see in the purple, those who are adequately insured at 11.2% reporting fair or poor general health. In the yellow, we see about 25.7% of underinsured Coloradans reporting fair or poor general health. And again, in the gray, for uninsured Coloradans, fair or poor mental health, fair or poor general health reported at about 24.3%. So we see that being underinsured and being uninsured is almost the same as underinsured and being uninsured is about the same experience. These two groups are twice as likely again to report poor health for both of these statistics and compared to adequately insured. So while those that are underinsured Coloradans, they still have access to healthcare coverage, it does not necessarily translate to actually accessing needed healthcare. These Coloradans still have cost concerns, which in turn can have downstream impacts on overall health outcomes. As these people continue to avoid getting needed care because of cost, just like uninsured Coloradans, because of this fear of these costs related to accessing care, their health will continually be impacted, leading to poor health outcomes down the road. Now let's look at how these different groups in Colorado feel about the healthcare system. So this figure looks at a kind of agreement or disagreement scale to the extent to which people agree or disagree that the Colorado healthcare system works for them and their families. In the green, we see those who are strongly or somewhat agree. In the kind of black in the middle, we see neither agree nor disagree. And in the light blue, we see those who strongly or somewhat disagree that the Colorado healthcare system is meeting their needs. Not surprisingly, uninsured folks do not feel that the Colorado healthcare system are meeting their needs, as they are faced with a whole host of barriers to accessing care. We see that nearly half of uninsured Coloradans do not think that the healthcare system meets the needs of them and their families. However, we also see a pretty large portion of underinsured Coloradans reporting this same issue at about nearly a third, reporting that they don't think the healthcare system is working for them. This is over twice the percentage of those who are adequately insured, where we see that about 10.1% of them reporting the same sentiment. So now that we know a little bit about underinsurance and what that looks like in Colorado and how it really impacts people related to their health, let's explore who among our neighbors is actually impacted by underinsurance. So first, let's look at age. So this figure looks at the age distribution among those who are considered underinsured on the bottom and those who are adequately insured on the top. So when we're looking at this age distribution, we are looking at those who are 0 to 18, 19 to 29, 30 to 34, 50 to 64, and 65 plus in these 5 different colored bars within these 2 populations. And what we find is in this kind of blue and orange color, those who are 30 to 49 in the blue and 50 to 64 in the orange, we see that there's a larger portion of these 2 age groups represented within the underinsured population compared to those who are adequately insured. And we're kind of calling these the working age adults. So next, when we look at these same 2 populations as it relates to ethnicity identity, we find that underinsured Coloradans are also more likely to be Hispanic or Latino. So when we look at these 2 populations, those who are underinsured on the bottom, adequately insured on the top, we find that statistically, the underinsured population is more likely to be Hispanic or Latino. About 25.4% of the underinsured population is Hispanic or Latino, compared to about 19.6% of the adequately insured population. And for our third demographic breakdown, we looked at those who live with a disability. So again, underinsured is on the bottom, adequately insured on the top. And what we find is that the underinsured population is statistically more likely to live with a disability than those who are adequately insured. We find that the underinsured population, about 25.9% of them live with a disability, compared to only 10.2% of the adequately insured population. So these three demographic characteristics were just a few of the many that we really looked at to try to understand more about the underinsured population. And these three were statistically different when comparing the underinsured and the adequately insured populations. Interestingly, the underinsured Coloradans group, that population, they are more similar to the uninsured population than they are to the insured population. So, as we continue to explore this issue around what underinsurance is in Colorado, it will be really important to understand some of the intersections of these socioeconomic and demographic characteristics to really better paint the picture of how certain Coloradans may find themselves underinsured in the first place. Again, it's important to remember that the CHAS data can only tell us some of the story, since actual plan benefits have a big impact on individual affordability concerns. For example, a plan's deductible greatly affects the total out-of-pocket cost of accessing care. Deductibles have continued to increase over time and are outpacing the incomes of many families. So while some demographic characteristics may be associated with being underinsured, the drivers could be more around individual insurance plan makeup and availability of lower deductible plans for Coloradans and their families. So now we're going to shift gears slightly into another exploratory analysis. We were really interested in understanding a little bit more about the types of care that may or may not play a part in driving underinsurance in Colorado. So let's take a closer look at this. So this figure looks at the percentage of people reporting specific care types that they didn't get due to cost concerns. So really breaking up that composite score that we've been talking about for the presentation and looking more specifically at those components, at specialty care at the top of the figure, general doctor care in the middle in green, and prescription medicines on the bottom in orange. So these values are for the consistently insured population. Again, those who have had consistent coverage for the last year, which is a component of our underinsured definition. So when we compare the percentages of consistently insured Coloradans reporting cost issues between 2013 and 2025, we found that specialty care cost concerns have statistically increased during this last decade for this continuously covered population, where we see 7.7% reporting this issue in 2013 for specialty care cost concerns, compared to 10.5% in 2025, where we saw a statistical increase between this time period, where we don't really see that shift in percentage for general doctor care. It's about the same between 2013 and 2025. And we see a little difference, but not statistically different for prescription medicines in 8.5% in 2013 and 9.3% in 2025. And some of this difference in cost concern issue for specialty care may really be explained by changes in utilization patterns over time as well. So this figure looks at the use of specialty care in the last year for all Coloradans over the last decade in this blue bar. We find that in Colorado, there has been a statistically higher percentage of people reporting specialty care use from 2013 to 2025, where we found that about a third reported that they had a specialty care visit in the last year in 2013, 35.1%, where we see that nearly half of Coloradans reported the use of this type of care in 2025 at 47.9%. And oftentimes we find that specialty care visits are more expensive than primary care visits. And certain types of care associated with those visits may really lead to higher out-of-pocket costs for people based on those differences in their benefit packages from their insurance coverage. So this is a very preliminary analysis where this was really striking for us, and we really want to dive more into this. But there may really be a story here around changes in utilization patterns over time, and really how specialty care costs may be making it harder for insured Coloradans to afford care, really pushing some of these insured Coloradans into that underinsured Coloradan bucket. All right. So that was a lot of new information. So now let's revisit our big points and our big key findings from this analysis. So again, our analysis showed that while the uninsurance rate has gone down over time in Colorado, the underinsured rate hasn't really changed since before the Affordable Care Act. Again, we find 13.6% of Coloradans are underinsured in 2025. And this 13.6% represents nearly 802,000 people and speaks to persistent affordability issues. And being underinsured has real health impacts. From health outcomes perspective, being underinsured is really basically like being uninsured when it comes to poor health outcomes, where we found that poor mental health as well as fair or poor general health had very similar rates of poor health outcomes between the underinsured and uninsured population. And finally, some groups are definitely more impacted by underinsured than others, where we walked through age, Hispanic or Latino ethnicity, as well as disability status for our specific demographic callouts for this presentation. And again, we find that underinsured Coloradans were more likely to live with a disability, be working age adults, and identify as Hispanic or Latino. Okay, so now we're going to open it up to the group. I think we've been fielding some questions in the chat, but we really want to turn it over to you all to really see, if you have any comments or questions related to the topic that we have walked through today around underinsurance, or really what's top of mind for you all as we're kind of thinking about what this means for when we're considering insurance status in Colorado.
Yeah, and thanks, Lindsay. We did have a couple questions come through during the presentation. The first is from Risha about how did premium cost, as opposed to point of care cost, factor into assessing underinsurance?
Yeah, that's a great question. So on other kind of data sources that kind of capture information on either premium costs as it relates to the benefits that people are paying into monthly compared to the out-of-pocket costs that people are paying as they're actually utilizing care. A lot of definitions are really looking at these out-of-pocket costs as these kind of premium costs are a little bit more, let's say, like known to the person up front. These are kind of the known costs that you're going to be using to actually pay for that insurance coverage throughout the year for your specific benefits. But when we're thinking about underinsurance, a lot of related to how we looked at it on the CHAS, but also from the Commonwealth Fund and other kinds of institutes or researchers that have looked into this, they really look at those out-of-pocket costs. And some might have more specific information on deductibles as well as actual co-pays and things of that nature. We don't have that data available on the CHAS, but there's other information out there around underinsurance and how they might factor in some of those other out-of-pocket costs into how they define underinsurance.
Yeah, thanks, Lindsay. And I'll just add again
Yeah,
that one of the national groups that sort of looks at this is the Commonwealth Fund. And they, as Lindsay mentioned, do just focus on these out-of-pocket costs and also exclude premium costs, though we know that that certainly plays a
yeah,
major role in people's decision-making around care and affordability and whether they get coverage at all.
yeah.
And as Lindsay noted, just on the CHAS, our question is really around whether these out-of-pocket costs, impacted your ability to get care and precluded you from getting care, whereas some of these other measures of underinsurance
Mm-hmm.
do use sort of like specific is your copay X% of your income and things like that. So
Mm-hmm.
it's not quite like a one-to-one alignment there, but
Yeah.
it's conceptually, I think, quite similar.
Yeah, and I feel like the premium cost issue might put like kind of this upstream impact of maybe putting someone at a likelihood of being underinsured down the road, as if they're kind of comparing these different benefit packages. They're looking at these different benefits. They're having to make decisions about maybe which premiums If it is like a high deductible plan, that might be more affordable at these known costs month to month. But because of that, that might then lead them to actually be more likely to be underinsured down the road
Mhm.
because of that. So it's definitely related. And I think it's kind of that upstream decision making that then might make someone more likely to fall into that group.
Okay, a couple more questions from the chat, and then again, encourage folks to also raise their hand, and we can take some verbal questions as well. But Phyllis asked about the increase in cost concern from 2013 to 25. So we saw on the chat that that has increased over the time span, particularly for specialty care. Could that also be a result of the age of Coloradans overall changing, so that age distribution changing, as well as perhaps the disability status of Coloradans changing in that time? So how do we sort of account for things like changing age age distributions and disability status over time? And is that something that we have looked into?
Mhm. Yeah, that's a good question. So I think part of this is kind of taking care of as it relates to the demographic distribution in Colorado through our statistical weighting process, where we do have a selection criteria built in. One of our like strata is around age for the CHAS, where we are trying to basically undersample the 65 plus population, oversample some of these younger age if it's like 18 to 24 and other age buckets related to how we're actually fielding the CHAS. So that is kind of accounted for when we're kind of doing our weighting process to make sure that the age distribution on the CHAS is actually relative to the age distribution in Colorado. But this is a really interesting point where if we see, our just overall age distribution in Colorado aging in a way that isn't like if we're not having younger folks, kind of supplementing and moving in and maybe more people having kids or what have you, this would have, I think, an impact on how we're thinking through the kinds of care that people are trying to access, and maybe the kinds of specialty care that folks are accessing as they're kind of aging. And I think to your point, this also kind of relates to this disability, living with a disability status, where it's like this different kinds of either, if you have a chronic illness or you have certain specific acute needs, you're definitely going to have a different kind of relationship with the kinds of healthcare that you're accessing every year. So while I think, we're kind of taking care of some of these, like maybe age distribution issues related to how we actually weight the survey, I do think this is a fair point. And as like if we are seeing a continued aging of our population, which I don't think we have seen an increase in just our average age for Colorado, at least in the last decade or so, because of a lot of changes in migration. I think this is something to definitely keep track of. But I would be curious if other folks have had this kind of experience with either who they're serving or like the kinds of folks that are coming in for different kinds of healthcare access points. I would be curious if anybody else has had that experience as well.
We could likely do some like age adjustment too to sort
Yeah.
of see how that has shifted over time.
Yeah.
Lindsay, I'm wondering if you might want to just kind of click through some of our other questions that we
Oh,
had
yeah.
on our Q&A, to see if folks might want to think about what you, as you know, Lindsay already prompted, what you and your colleagues are thinking about as it relates to coverage and sort of how this concept of underinsurance shows up in your own work. If you want to click again, how we could use the CHAS to help answer some of these upcoming questions in your work. So I think that this comment about, how has the population itself shifted over time, and then how is that impacting some of these outcomes that we're looking at is a great one. And I think one that we can look at through the CHAS, especially for age, but
Hmm.
disability status, we can go back a certain number of years, but that's actually one of those newer questions that we added to better capture sort of the experiences of that community. So, again, happy to take additional questions in the chat, or if folks want to raise their hand, we can also take questions verbally or comments if folks just want to talk about how this is tracking.
Hmm.
And if not, Lindsay, I can ask you one of the questions that I had early when we were sort of starting this analysis, which is how does underinsurance differ, or does it
Mhm.
differ for different insurance types?
Yeah, this was really interesting because this was one of the first like kind of characteristics I looked at. And we actually find that there is no statistical difference between the different insurance coverage types that we capture on the CHAS. So I compared Medicaid CHIP kind of as a one group, individual marketplace, employer sponsored, as well as Medicare. There was different percentages across these populations, but they were not statistically different at all, which I found very intriguing. Where I was like, I was imagining maybe we would see some differences perhaps in the kinds of actual insurance coverage that people are reporting that they have their insurance through. So that's why I think there is like this next level of this like intersectional analysis that I think would be really helpful to try to further understand, Phyllis's question around age, disability status. Like, I feel like there's something more here related to individual plans and maybe individuals' experience and their ability to access different kind of plans, perhaps. Like, I looked into those who live with a disability, and they are, if they're employed, they're a lot more likely to be underinsured than if they are not employed. And those who are not employed are getting a lot more benefits from public insurance coverage types because a lot of them are reporting that they are unable to work because of the disability that they have. So I think there is some more complex like intersectionality between these different demographic, socioeconomic characteristics, because also income alone did not explain differences in underinsurance either. So it might be a combination of some of these things to really understand what puts someone at much higher likelihood based on maybe the kinds of plans that they're accessing for an individual person in Colorado.
Yeah, that's really interesting. I would have thought that income would have had a bigger
Same.
role in
Yeah,
sort of
those are
being
the first two I
protective.
started with, and I was like, huh,
Hmm.
interesting.
Yeah. I do want to just go back to again sort of this age adjustment question because we're getting more clarification from the ether here. So as Lindsay mentioned, the median age in Colorado has actually remained steady, and that's a result of both the population aging as well as sort of more folks coming in who tend to be on the younger side of the age spectrum. The population of folks who are 65 plus has increased during that time frame, but likely not by enough to really account for the shift in the rate of people being unable to afford specialty care.
Mhm.
So when we sort of try to square those together, it doesn't fully account for that, but there are some trends there that certainly are
Mhm.
playing a role in other places.
Yeah.
Okay, again, open to other questions, comments, reactions. I know that we have lots of folks on the line who think about this and work in this space a lot. So would love to hear if, again, this sort of tracks with your own experiences of people being underinsured, and how that then impacts how people show up, whether it's health outcomes or other. Otherwise, Lindsay, if you want to go ahead and go to the next slide. Um, Again, we know that this was a lot of information and it is all packaged on our report that is online that you can access by scanning this QR code. And we encourage you to check it out. You can also download it and share it with others. But again, would love to continue to hear feedback and be part of this
Mhm.
conversation. And
And one thing I want to mention as well, Suman, is that we've had folks reach out to get kind of regional estimates for underinsurance in your area. So that is definitely something that we can look into if you have a question about what underinsurance looks like in your specific region. We can also do that as well. So you can
yeah,
reach out to me if you are curious about that.
great. So before we wrap up with some other resources, I'm just going to do a final check here to see if we have questions or comments. It looks like we do have a comment about how at safety net clinics, we have to rethink how we define the
Mm,
populations we serve to not just uninsured, but also thinking about those who are underinsured. So thank you, Laura, for sharing
yeah.
that. It looks like we might have had someone with their hand up. Rhonda, I don't know if maybe you had it up by mistake or if you wanted to come off mute. Great. Yeah, let's go ahead and give you a chance to come off mute.
I was just wondering how the statistics look for health insurance premiums that have increased, where the people that were insured are no longer able to be insured because of those premiums.
Yeah, that's a great question. And right now in the Chaz do not ask questions about premium cost. It is something that, as a teaser, we're sort of exploring for future Chaz surveys because we know that there have been it's always something that is a potential concern, and especially with some of the policy changes that we've seen over the last year, we know that that is even more at play in people's decision making. So unfortunately, we don't have an answer for you based on CHAS data specific to premium cost. What we can look at is how general trends in coverage have changed, and might be able to speculate on how that's related to premium cost. But potentially in future CHASs, we might have more to say there.
Hmm.
Great question, though. Um, okay, and then another great question from Phyllis about sort of, again, just trends and people seeking care. So people who are underinsured with high deductibles might not actually know that they have a high deductible because they haven't actually sought healthcare. And so that certainly is a limitation in this data and, transparently with survey data, right? We're working off people's own self-report and their own experiences and sort of
Hmm.
navigating the healthcare system. So we certainly know that there are some metrics that are sort of again based off of perception of what something
Yeah.
might be versus what their actual plan might say. So thank you, Phyllis,
Yeah.
for raising that.
Yeah, and the healthcare affordability questions related to those different types of care, they are not limited to those who are just seeking care in the last year. So it really is, to Simon's point, like I thought about seeking care, but I was scared of what it might cost or what have you. Like it is everyone's. It's asked of the entire sample, so it could be people that sought care maybe once in the last year, had to pay more than they thought they would, based on the plan that they have. And then maybe the next visit, they did not seek care because of that. Or it's people that are just concerned about what that cost is upfront and might not have sought care at all in the first place.
Yeah, I think, obviously these decisions are complex and
Yeah.
require a lot of different factors, and we try to sort of assess a few of them, but um, not always a perfect measure, but
Hmm.
hopefully giving some context to things that we do think are generally happening. Okay, well, before we wrap up, thank you, Joe, for posting the link to where the recording of today's webinar will be posted. I do just want to share a few other CHAS resources that we have available, including a new resource. So typically our CHAS data, we report statewide numbers, as Lindsey has shared. We also report data for health statistics regions, which tend to be sort of larger groupings of counties across the state. And then actually this month or last month, for the first time, we were able to do some additional statistical modeling to create county level estimates of a select number of CHAS indicators. So our county data is available online at colo.health/county data, or you can scan this QR code. It is right now just a select number of indicators, and it's sort of meant to be a starting point, but we encourage folks, if particularly if you work in a county that typically has not had reportable CHAS data, we encourage you to check these out. And again, we'd love to sort of get feedback on how this data is tracking for you, how you're using it, and more. And then final slide for our CHAS resource PSA here. We have a lot more data. So even if the county estimates are not your thing, we have our sort of typical CHAS data available in a lot of different formats. So again, encourage you to check it out. We have this report posted there, as well as many others on a variety of topics. And we always appreciate those of you who will spend 8 a.m. on a Wednesday morning talking about data with us. So thanks again for joining us, and hope to see you at our next Hot Issues webinar.